We've heard some really inspiring descriptions of efforts to improve health. One of the common requests has been for a sustainable is that better? Okay. For a sustainable funding model which would support these initiatives. That's going to be the focus of my presentation. So the theme is summarized here. The healthcare system is transitioning from a payment system that rewards volume to one value-based on triple aim's outcomes. I think it's pretty clear that we're in the midst of that transition. This could create a funding stream to reward improvements in population health, and a window of opportunity exists to shift to more sustainable funding models for population health. However, the complexity and relative weakness of key building blocks for population health payment models creates the threat that they will not be incorporated in new payment models in a meaningful way. I think that threat is real, and I'll develop this for you as we get into it. So I'm going to spend a little bit on some context, do that pretty quickly because we've covered some of that in previous speakers. I'm going to give some examples of the transformational models of service and payment that are being developed at the national level through CMS, but also at the state and local level, using Vermont as the example. I spent 2 years at CMS as the acting director for the Population Health Models Group. I've been involved in the Vermont work for over a decade. Some of the colleagues, Paul Jarris, was helpful in getting that started. It's an interesting exercise to take about 5 minutes each to describe the work that's going on, but we'll take a crack at it. But I'd like to then conclude by focusing on the opportunities and threats for population health financing. So the context, again, we've covered this, the goal of delivery system reform is universal access. The issue is cost, and how do you control cost? The approach is transformation. I underline transformation because we're not talking about incremental change in the delivery system. We're talking about how do you transform it in a significant way in order to create one which rewards triple aim's outcome. That is no small task. A new aligned payment model is a necessary but not sufficient condition for transformation. But it is an essential part of what we're getting where we're trying to go. The conceptual model that I like to use is the one which you've seen before, Neil Halfon's Healthcare 3.0, where we're moving from a healthcare system 1.0, which focuses on episodic acute care, to 2.0, which is a coordinated care system. A lot of the work that's going on in the new service models are focused on coordinated care, whether it's patient-centered medical homes or ACO. The third stage is the Healthcare 3.0, which is a community-integrated healthcare system, which gets at the root causes and the determinants of health, and there are relatively few organizations which are really focusing on that. But that's where we need to go if we're going to control costs over the long term. So, innovation and payment reform. At the federal level, the Innovation Center has really been involved in creating what I call building blocks for transformation. And it's really at the state and regional level that you see how those building blocks get assembled using the unique conditions and starting points that you find in different places to do the transformation. So I'm trying to give you a little glimpse into both of those levels. The vision that Don Berwick established at CMS when he went there was for CMS to be a catalyst for transformation. CMS as a constructive force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. Our principal responsibility at CMS was for our beneficiaries and for the well-being of our beneficiaries. But we realized that there was no way that we could get the performance that we needed out of the new healthcare system if all we did was focus on our beneficiaries. We had to transform it for everyone. So that's why we placed an emphasis on, even though we're a dominant payer in the market, we needed to collaborate with other payers so that the delivery system was facing an aligned set of financial incentives which would support the change that was needed. As long as they were schizophrenic, continuing to live in both a volume-driven fee-for-service world, and a value-based world, you would never get where you needed to go. The Innovation Center was created to identify, test, evaluate, and scale those kinds of changes in payment models and delivery systems. It was funded with $10 billion in funding for over the 9-year period, and most importantly, it had in the legislation the opportunity to scale up its findings if the actuaries certified that the new model was working appropriately. The Secretary could take it to scale nationally without having supporting legislation. That's a tremendously powerful and little understood authority for the Secretary. The strategy that the Center used in transformation was we recognized that the delivery system really was at very different starting points across the country. And what we had to do was to develop a portfolio of initiatives that met providers where they were on this path for transformation. So if you were a hospital that has no experience with risk sharing, no experience in trying to really do coordinated care, a bundled payment program which lets you get some experience in a very narrow slice of one clinical area on how you work with physicians, how you work with other providers for a comprehensive payment would get you started on this. In contrast, if you were one of the sophisticated California or Massachusetts provider systems that have been working with global capitations and global budgets for decades, then we had the pioneer ACOs to try and move them further along. So at this point in time, the Innovation Center has more than 40 different model tests that are underway, in filling in a broad portfolio to accomplish this. The measures of success should look pretty familiar. Now, better health care in terms of the experience for patients, better health for the population, lower costs through improvement. These measures for success were built into the funding opportunity announcements for most of the model tests and into the way that they're being evaluated and assessed. So the placeholder of saying that we wanted to achieve a transformation which delivered triple AIMS outcome, which improved population health, was built into the DNA of our programs. The population health program at the Innovation Center had 4 components to it. The first one was measures, developing a more robust set of measures for tracking changes in population health that could be used in payment models. The second was the testing of new models of payment and service. Part of what we did was to strengthen the population health focus in all the models that we were testing. And then we had our own set of initiatives, particularly the ones that came in for the first round of the Healthcare Innovation Awards. I want to emphasize there's a second round of Healthcare Innovation Awards that's now underway. They explicitly have a focus. One of the 4 focal points is improvements in population health, and we think that is going to be a major opportunity for a second round of test of service and payment models. The third aspect of the program was building collaborations across a wide variety of stakeholders, private and public. And fourth, promoting and teaching. We were a catalyst. We tried to identify case studies, and we were teaching, providing webinars and other teaching on population health to a variety of programs. So that's an overview of the federal initiative. Again, I'm not going to take the time. I don't have the time to go in detail into the specific building blocks, but the portfolio that was developed, I think, is a very helpful and effective one. Vermont has been working on the delivery system transformation for over a decade, since about 2001. It's an ideal laboratory for healthcare reform, 600,000 total people, 13 hospital service areas, none of them overlapping. We don't have competing hospital systems within a geographic area. And a spirit of collaboration in the state, which made it possible to do things which I wouldn't imagine anyplace else. The innovation in the service models That's strange. The innovation in the service models occurred at two levels. At the primary care level, the blueprint for health is an enhanced medical home model. We started in 3 communities piloting for 10% of the state's population. 3 years ago, the decision was made to expand that statewide. We felt it was working. So as of the beginning of this year, 75% of Vermont's population had access, was being served by primary care practices that were part of the Blueprint Medical Home Project. The Blueprint has been expanding its design, developing a stronger set of community linkages into smoking, diabetes prevention programs, et cetera. They've also developed the SASH support and services at the home residential program in 40 sites, which embeds a care coordinator and community health worker within a housing program to provide support. There's also a new innovative opioid-dependent program, hub and spoke program, which is being implemented. It runs out of the medical homes with support from hubs of specialists, and that'll also be statewide in January of 2014. What I want to emphasize is these are no longer pilots or demonstrations. These are efforts that are being implemented statewide. At the community level, the Blueprint has community health teams that are available and embedded in each one of the communities that provide additional resources to the primary care practices. Again, those community health teams have been expanded statewide as well. We have our Medicare ACO. The One Care program is a statewide ACO which incorporates Dartmouth, University of Vermont Hospital, and 13 community hospitals, which will be enrolling about 50,000 seniors. That is part of the Medicare ACO program already in place. So again, the implementation of a service model which is integrated at the primary care practice level and at the community level on a statewide basis is well underway. The payment models at the primary care physician level, the primary care practices have a capacity payment which is based on their ability to meet the NCQA patient-centered medical home requirements. The payment is scaled up to a max of about 50,000. It's a PMPM payment, but it's scaled up to a max of which is equivalent to about 50,000 a year per primary care physician. This is an all-payer program which includes all the major commercial payers, Medicaid and Medicare, through the MAPCP demonstration. The SASH program is a PMPM payment as part of the MAPCP demonstration as well. The substance abuse program is a Medicaid Health Home 2703 program. We're looking at the concept of a payment, future payment, which is based on both the capacity as a medical home, but also a performance-based score, which takes into account potentially the impact not just on medical expenses, but corrections, employment, and foster care. At the state level, we have received a state innovation model testing grant, and we're implementing testing shared savings model statewide, bundled payment, and pay for performance. As part of this effort, we've implemented, we will have a population health work group. So the state, again, is pretty far along in terms of the transformation of the delivery system and the formation of and the development of the payment models that will be used in that system. So, delivery system reform and payment and population health. Where are we, and what are some of the opportunities and threats? So, there's a really, as you've heard from the presentations earlier today, there's broad diffusion of this language supporting better health for populations, triple aims outcomes. It's in the public conscience. We have new payment models being tested, again, not just at pilot levels, but at scale in Vermont and a number of other regional markets. There are new options for financing, hospital community benefit, the Bank Community Reinvestment Act, social impact bonds. There are signs of payers aligning in regional markets. The Comprehensive Primary Care Initiative required payers to come together We got 7 markets where virtually all the payers in the area agreed to collaborate with Medicare in aligned primary care payments. So it's some very promising signs there. However, I want to emphasize this, the delivery system evolution lags the rhetoric with a broad distribution across Neil Halfon scale. There are a lot of people, a lot of care systems out there that are still perfectly happy to stay in 1.0. It's working for them, fee-for-service is working for them, and they're not going to change until the new system is clearer. Very few are exploring the path to 3.0. The challenges for population health financial models is that when you look at the triple aims, the other dimensions of total cost and patient experience have a long history of being used in payment models. The interventions are better understood, people know what to do, the measures and instruments have been developed and they're implemented at a granular level within the provider systems so that they can measure their accountability. And the accountability is more clear-cut. The providers feel more responsible to this stuff that they control more directly. A second issue is that the task of transforming to managing total cost and patient experience is all-consuming. We heard, previous speaker talk about the exchanges sucking all the available options, and well, I can assure you those pioneer ACOs, even the people who are very experienced in doing this, making the transition to managing under a Medicare shared savings program where you have an attributed population rather than an enrolled population, where the data is you're getting and feedback on performance is lagged and not what you really need. Making that work is all-consuming. So that next, the population health business case is complex. It's complicated. And it requires, the long-term sustainability requires reinvestment of shared savings, not just from the health sector, but if you really want to do the job right, you do have to anticipate the impact of wellness on other sectors. As I mentioned, that opioid dependency, we're expecting major impacts on corrections. We're expecting major impacts on employment. And if you want to capture the benefit, and you want to capture the value, you need to be able to do that. That is not an easy thing to do. So integrating population health into delivering system reform is intimidating. The determinants of health, I will tell you, are not readily understood outside the public health and population health community. Yeah. There is a tendency to focus on the familiar, the clinical services that healthcare providers control directly, even though that represents, as we know, 10 to 20% of the determinants of health. Another issue is that the portfolio of validated interventions for key risk factors, for example, obesity, is thin. It's small. We're still learning how to control that. And finally, the measures are poor. And I find a tremendous confusion, as I talk to people about this, between quality of care and population health. Many people, when they say we're measuring triple aims outcomes, and you ask them what the measures are, and the measures are of quality, healthcare quality, rather than true population health measures. So, differentiating those is, when they do focus on population health, again, the focus is on clinical measures of care. If you take a look at the quality measures that were built into the pioneer ACOs, there are some population health measures, but they're just clinical in nature. They don't do the job. So the threat is that our payment models for population health are in the early stages of development. As we know, population health should traditionally be funded by grants, taxes, not payment for service, not for the value. The infrastructure and tools for population health improvement are not well developed. The models for projecting, the analytic models for projecting long-term impacts are still in an early stage of development. And a lot of the benefits that we want to capture do happen over a longer period of time. So we need to have more credible models. The business case for payment models is fundamentally different from assessing their impact on risk factors. Just because CDC validates that something has worked in terms of reducing the risk factor that doesn't complete the story of making the business case for why we should include that in the payment model. How do you value those changes in impact? So the risk, as I mentioned, is new payment models will be established with no meaningful payment model population health component. How to pay for population health? This is a question, a simple question to ask, but it's one that's remarkably difficult to answer. What do we want to pay for? Do we want to pay for changes in risk factors? Do we want to pay for changes in life expectancy? Do we want to pay for changes in well-being? Because the whole question of health involves a quality of life experience. What do we want it to pay for, and how do we value that? It's hard to answer, but I can guarantee you we will not get the community health system we need, Alphonse Healthcare 3.0, until we learn how to answer it. Thank you.
Thanks very much, Jim. Our next speaker is Wilma Wooten. Dr. Wooten is the director of the San Diego Department of